If you've ever wondered, what is it like to work in the hospital doing inpatient medicine, be a hospitalist PA or an NP, then this video is for you. Today I'm interviewing a PA who's worked in hospital medicine for several years and actually does like 3 different type of jobs all under the hospital medicine umbrella. So if you're curious to learn what it's like and what the different opportunities are, then stay tuned. Hi, it's Michelle with the Medicine Couch, and I really appreciate you being here and joining me on this channel. Now let's dive in and hear all about hospital medicine.
So hospital medicine is basically primary care, but for people who are in the hospital. So people who are too sick to go home, they stay in the hospital and they need someone to watch them, take care of them on a daily basis. And so that's where hospital medicine comes in.
So you're kind of like the driver of the ship for the patient when they're in the hospital, because then I assume that you will interact with specialists and things.
Yeah, absolutely. So if a patient gets kind of tricky or if they're getting sicker, we definitely have specialists that we can involve.
So tell us a little bit about, paint a little picture of what your daily life is like when you work as a hospitalist. Like, what do you do on an average shift?
So my schedule is I work 7 days on, 7 days off. And during those 7 days, I'm doing the same thing. And so majority of the time...
7 days on, like how many hours is each shift?
Yeah, so each shift is about 10 hours. So we work about 70 hours in that 1 week. But that being said too, and we can talk about it if you want, but I'm not at the hospital the whole time, every time. So it's not quite so bad. Yeah, so to describe kind of what I do on an average day or average week, I'd have to talk about 2 different things. So we do primarily rounding on patients, which is what we do where we follow a patient once they're admitted to the hospital, or we do it admissions. And so we'll go down to the emergency room, admit somebody to the hospital and create their initial plan, talk to specialists if we need to get them involved right away. And so if it's a rounding week for me, what happens is I, get there in the morning, usually around 7:30ish, 8 o'clock, review the chart, see what happened overnight, if there's any cross-cover notes. So if anyone got called about my patients after I left, look at their labs, look at any kind of specialty recommendations, and then I go and see them. And I see how they're doing that day, talk to them. Are you feeling like you can go home? Or based on what I'm seeing, you need a few more days in the hospital? And of course, we have physical and occupational therapy who helps us with those decisions too. And if it's an admitting week, what I do is I go in and I get there, depending on the times, we start at variable times for those. But I go in and then we just wait until the emergency department says, hey, I have a patient for you. And then we rotate through the amount of people they're doing admissions. And so usually we get about an hour to an hour and a half between each admission that we're doing. And then that day I'm just focused on getting them their initial plan settled in. And then I don't ever see that patient again. It goes to a rounding team the next day.
So 1 week you round, like the whole week, every day you're just rounding on patients. And so you're, following them day to day, getting in orders that have to happen for that day and making sure the patient's got everything, going that's supposed to and keep up with how they're doing. But then on other weeks, you are just on the admitting service. So all you do is admit the patients as needed from the ER and get their plan started. And then a rounding team will take over after that. So you guys go back and forth each week about what you're doing?
Yeah, it's not consistently like every other week, but those are the kind of the main 2 options for us to do. And we do other things too. We can talk about other roles that I do as well.
And this is what's interesting about hospital medicine, because I did a short stint as a hospitalist, and it seems like every hospital does this differently. It makes it interesting but challenging if you're looking at a hospitalist job, because you can't assume anything, right?
Yeah.
I mean, you have to ask those questions when you go in to interview, like, how is it set up here, right? And what are you doing? So let's talk about like number of patients that you have when you're doing a rounding day. Like, how many patients are you responsible for that day?
Yeah. So as a PA, we have, they call it a cap. So the max amount of people that would be assigned to us per day. And that cap is typically about 10. So I'll round on 10 people that day. Depending on acuity or patient census, it might be lower, but 10 is pretty much the max that I'll ever see during the day.
Yeah. Okay. And, some people may think, well, that's 10 patients in a 10-hour day. Oh, you got an hour per patient. And I'm sure there are some days where it's like you feel a little luxurious, you've got a little time, but I'm sure that there are other days where if a patient has a lot of needs and a lot of orders you have to put in and a lot of just thinking about what is happening in their condition and talking to specialists and stuff, that 10 patients can seem overwhelming, I assume, right?
Yeah, absolutely. Like you would think everyone would constantly be leaving early, but quite often people are there, later into the evening sometimes, or even staying past their shift. And that's exactly kind of what you're talking about. Sometimes it's kind of wrangling a plan between two specialties. So, if general surgery is involved and ortho, trying to corral them together to kind of see what is our plan, what are we doing? Or it's having patient care conferences. So if your patients are super sick or the discharge plan is complicated, we have to coordinate and then meet with a whole bunch of families, and that's usually an hour long. And so just all of those little extra things that come along with being in the hospital do add time. So you're right. If I was just seeing them, I could probably be out of the hospital in 2 hours. But there's just a lot more that goes into it.
Yeah, it's complicated. And so when you're doing the admitting, how many patients, like, do they have a cap on that, or how many are you expected to admit a day?
Yeah, so we have, where I work, we have kind of like a soft cap of 7. So kind of 7 admissions. I call it a soft cap because if it's super busy, everyone's seeing a bunch of patients, you might see 8 or you might see 9. But we do have a mechanism in place to call somebody else in to help us, just because at some point that number, does become unsafe if you're trying to figure out someone who's pretty sick.
Yeah, and again, that's very variable, the number of patients. So when I worked at that hospital, all we did was admitting. And so the PAs and NPs during the day shift never did any rounding. We just did admits. The night team, they were responsible for like handling the floor and floor call and, keeping up everything happening through the night and putting in orders and things. And they would do some admits, but that wasn't their main responsibility. So in the day shift, when we did the admits, we worked 12-hour shifts, and we were expected to admit 8 to 10 patients a day. And like you said, sometimes, and they don't just come nicely, like, here's one, and an hour later you get another one, right? I mean, there's times you get like 3 admits all at the same time, and it can be difficult, right? Because then you have to decide, like, who has the highest acuity that needs to be dealt with first, and get orders in and get things going and get eyes on them and things. So one of the things I didn't understand transferring from outpatient to inpatient was all of the other things besides like just their diagnosis and medications that you have to put into place. Can you talk about some of those things, like that people may not even realize that you are responsible for ordering?
Yeah. So there's a lot of other things that we have to order besides, medications. Definitely, I think one of the ones that might fall in that is the consult. So we have to figure out who needs to see this patient. And then we need to kind of write a brief reason in the order so they know what we're asking about. Some places we also have to call them and give them an update. Other orders we have to do would be like a diet order, deciding can they eat, and if they can, what kind of diet. So if they're a dialysis patient, we have to choose renal diet. If they have heart failure, we might choose low sodium. So kind of thinking about that. And then thinking too, do they need any other like ancillary services? So do I need PT to see them, OT to see them, speech? Does the dietitian, would that be helpful in this scenario? And then social workers and case managers where we work pretty much see every patient. But if we have a specific concern, then putting that consult in with that reasoning too is very helpful. And then even remembering to order, does this patient use a CPAP at night? So you have to know that. And so because it might be totally unrelated to why they're there, but they need that CPAP. So all those little extra things and other things too would be like delirium precautions. Like, would they benefit from delirium precautions? Do I not want them to receive benzodiazepines in the hospital? We can put a restriction order in their chart. So just a lot of other things to think about besides just their diagnosis.
Tell me a little bit about how closely you guys work with the physicians. Like, what is your autonomy like? Are the physicians also seeing your patients, or are they just your patients? How does that work?
Yeah. So it differs a little bit again between the rounding and the admitting. So I'll talk about admitting first. When we're doing admissions, we're pretty much autonomous. If someone's super sick and we're worried, we might touch base with a physician who's also doing admissions. But oftentimes they just kind of mull it over with us. They don't actually go see them unless we're like, hey, can you look at this person? They look terrible.
Yeah.
So for the most part, autonomous. And then when we're on rounding services, we do what's called paired service. So there's a physician that we're paired with. We're on a team is what it's called. So I'll have 10 of my own patients. They'll usually have 14 of their own patients. And then at care rounds, which includes like social work, pharmacy, PTO, all those people too, they'll hear about my patients. And then if they're like, hey, like, are you doing this for that patient? Or if I'm like, hey, I think this person's getting worse despite everything I'm doing, then the physician would get pulled in and see them. But on like a day-to-day basis, they're not seeing all of my patients.
What is your typical schedule like? Because this is something that can also be very varied. And we worked, I'll say, we worked 7 on, 7 off, and they were 12-hour shifts. So 7 12-hour shifts in a row is quite the grind. And then you have 7 days off.
Yeah.
How does your schedule compare to that?
Yeah, so we also did the 7 on, 7 off, so 7 days in a row, then off for 7 days. So, but it's not so bad. So, I mean, the hours, if we're rounding, are 7:30 in the morning until 6 p.m. But we can usually leave around 3 or 4 p.m. And so you can be home, even though you're still working, and just responding to pages. So maybe there's a question, your patient got back from the OR, can they have a diet order or something like that? You can address that from home. So I think that really helps with like the work-life balance, is I'm not tied to the hospital the entire shift.
Yeah.
And then with admissions, it depends on the time of day, but those are, typically 2 p.m. to midnight. So again, 10 hours, but we get our last admission an hour and a half before the end of our shift. So if we get kind of caught up or there's nothing going on, we can leave a little bit earlier. So I think that our group at least has really built in these like protections for like work-life balance.
What about holidays, weekends, all of that stuff? Does that matter when you're in the hospital if it's a holiday, or
It doesn't.
are you working?
It doesn't matter for hospital medicine. If it's a holiday or a weekend, we're still there. It does matter what procedures are available or if people can discharge to facilities. Some facilities won't take people on the weekends. So, but for us, having to see the patients, we pretty much have to do the same thing regardless of if it's a weekend or a holiday. And so I work, since it's 7 on, 7 off, essentially every other weekend. And then our group, for holidays, we only recognize, and I say we as a system, this wasn't my choice, but we only recognize Thanksgiving and Christmas. So every other year you work either Thanksgiving or Christmas, and then the rest of the holidays are just like luck of the draw.
So your hospital doesn't have PAs and NPs working overnight, but a lot of hospitals do. So people are thinking about hospitalists as well. That is something to be aware of. And oftentimes the night shift, as you would assume, is harder to staff than a day shift. So if you're looking to get into hospital medicine, you may have to work the night shift, for a while. You just have to just be aware of that. I mean, you may get lucky. Like I got lucky. I got on day shift right away, so I didn't have to do the night shift thing. So a lot of hospitals do have PAs and NPs that work overnight, and they're basically covering the floor. Like you said, they're answering the questions the nurses have and sending in orders and anything that the nurses need for the patients. I wonder, do you do like any procedures as a hospitalist?
So there's opportunity to do procedures. I'm going to say that I usually don't. But in our group, some of the PAs and NPs will do skin biopsies. So we do them all for like dermatology. We have telederm, so they're not in the hospital. So we need someone to do the biopsies. So they're skilled at doing that. I guess I do point of care ultrasound, which I guess isn't technically a procedure, but it's something that I have added to my practice. And as a part of that, I could learn and be trained how to do like paracenteses or thoracenteses. I just haven't done that yet, but that opportunity is there if you want to do procedures. But for the most part, especially I also work in the metro area, so we have a ton of specialists. So usually we save procedures for the people who are excellent at it instead of just doing it ourselves.
Right, yeah, the people that do it day in and day out. Yeah, so it sounds like that if people are interested in procedures, there's probably more procedures done in the emergency room or more procedures done in the ICU, and the hospitalist, not as many, right?
I would agree with that, yeah.
Yeah. Okay, cool. So what kind of things in this specialty have been a surprise to you, or the things that you really enjoy about working in hospital medicine?
So yeah, I guess what was a surprise, but not quite a surprise, but just very obvious working in the hospital, is how much social determinants of health impact our patients. So for example, somebody might come in with pneumonia and they're weak. if it was me, I have resources, I have family, I might go home on antibiotics, but this person might have no one to help them, nobody who could bring them water in bed or cook their food, and so they're getting admitted just because they don't have resources. Similarly, like when we're looking to discharge somebody, sometimes it's like they're newly diabetic, but they're homeless. And so how are we going to manage their diabetes to keep them out of, diabetic ketoacidosis
Right.
if they can't access insulin or can't access, all the fancy SGLT2 inhibitors or GLP-1s? So it's just really like obvious, I think, in these settings, kind of how social determinants play into our patient care.
Yeah. Yeah. Well, but what are some of the things that you enjoy about working in the hospital?
What I enjoy, I really like how much you have to think, first of all. I really like getting to think about every single thing that's going on with the patient, which is a stark contrast to when I did urgent care, where I was very like chief complaint focused. So I really enjoy getting to look at the whole picture, playing with all their medications, that kind of thing. And another thing that I love about hospital medicine is the interprofessional collaboration. So I'm not working by myself. There's pharmacy helping me. There's physical therapy, occupational therapy, speech. There's a social worker, a case manager. There's just so many people that are on your team. And so patients really, which makes sense, they're sicker than someone who's just walking the clinic, right? But, patients really have a lot of resources at their fingertips at that time, which is great.
Yeah. Yeah, and it can be lonely, like in family practice. Oftentimes you may work in a practice where there's like 2 or 3 other providers, but you're always going in and out of the rooms. You have no reason really to interact with the other provider unless you have a specific question to ask them. You may talk to your MA a little bit, but you're always so busy that there's no like real social aspect. It's very isolating. And in specialties, I would imagine even more because they probably have even smaller offices. But in a hospital setting, like you said, you're interacting, with the nurses and the physicians and the specialists and the social workers and respiratory therapy and everybody. So if you're more of a social type of person, that really can help keep the job from feeling so isolating, right? I mean, not that you have time to sit around and gab by any means, but still just interacting with other people is nice.
Yeah, I mean, even like when we're doing admissions, we're going down to the emergency room and interacting with the emergency medicine doctors. And so, or PAs, they have PAs at our facility. So, it's just, there is a lot of social interaction.
Yeah, and you're all over the hospital because you have to go to different floors too and stuff. So, it's kind of cool. So you already talked about the social determinants of health being a kind of a big factor when you're in the hospital, and it's true. I mean, sometimes you're like, what do we do with this patient? We can't send them home, and sometimes it's not always easy to get somebody into a facility. So those things can be very tricky. But what are some of the other things that are kind of the downsides of working in hospital medicine, or things that people really need to be prepared for or think about if they're looking at this specialty?
Yeah, I think one thing that I have had to grow into is I wasn't so prepared for all the challenging conversations I would have to have because people are coming in sick. And so, I would say most of our patients do recover and they get better, but you do sometimes have to have those hard conversations of, hey, like your mom, your grandma, your grandfather, he's really sick and I don't think I can fix it.
Right.
We're kind of headed towards end of life care and having those discussions. So I think you need to be comfortable, or at least willing to learn how to be comfortable having those conversations. It's definitely a skill. Some people are better at it than others, but that's one challenge that I've identified.
Yeah, and do you guys have palliative care in your hospital? The palliative care team?
At 2 of the hospitals I work at, we have all the time, and then at the other hospital, they're there twice a week.
Oh, okay. Yeah, and if people aren't familiar with palliative care, so there's palliative care and then there's hospice. They're not the same thing. And palliative care can be for anyone who's going through a really hard, challenging diagnosis or treatment. Even if we expect, full recovery or hope for full recovery on the other side of that, palliative care is there to help kind of manage the patient and their expectations and help them go through this challenge how they want to as a person and their dignity and stuff. So I interviewed another PA, Tracy Paparo, who works in palliative care, and I'll put that interview up here if people want to check that out, because that is another really interesting job that happens mostly, in the hospital. What else? Is there other downsides to the hospital?
I really enjoy my job, and so it's kind of hard to think of too many downsides. I think just kind of what we've hinted on before is, the hospital is always open. And so, patients keep coming in and they come in. And so just because I only want to admit 7 that day, I might have to do more, and I might be tired, and it might be every day of that week. Or there might be one day where I admit 1 person, which is super boring, and then the next day it's like I'm constantly running around.
Yeah.
So I think that variability can be challenging sometimes because, although it'd be great if we all showed up as our best self every day to work, that just isn't true. And so if you're showing up kind of exhausted that day or hungry, or you're in
when you're on day 7.
Day 7. Yeah, day 7. I guess I could just say day 7's a challenge. That's a challenge. Because your patience is super small that day. That can make it challenging because it doesn't stop.
Right.
So, you can't block your calendar or block an hour.
Yeah. Yeah. The things I would probably say about good and bad, the good thing, which is nice compared to outpatient like family practice, is that once you are done for the day, or your week is over, you don't have to think about your job at all in your off time, right? I mean, you're not like primary care. You're thinking, sometimes you're even checking labs at night, or that there's some referrals that have to be made, or that if you go on vacation or take some, a day off, all your inbox is going to pile up. That doesn't happen in the hospital because you have, I'm sure, messaging and inbox, but it's not an inbox like outpatient, right? I mean, you don't have things stacking up that you have to go through every day. How does that work?
No. So the way we do it is if someone gets discharged and there's like labs coming back or blood culture is still coming back, it goes to a group pool. And our PA or NP who's working over in behavioral health doing medicine consults over there, which is another role that I do, they go through those results. And if there's anything that needs to be addressed, they address it. If they don't know how and that person's still working that week, then they reach out to that provider. And then we also have nurse clinicians that also help with the in-basket. So they'll go through and kind of manage things that, don't necessarily need a provider decision or evaluation.
Yeah. And when you leave your shift for the day, it's not like the patient's just, left without anybody. The night rounder or whoever it is, they have control of the patient at that point. So any labs coming back while they're working, they take care of and handle. So it's kind of nice with the hospital is when you leave, you can just kind of decompress. I mean, you may have thoughts about what happened that day and things, but as far as, lingering work to do, you don't have any of that. And when you go on vacation, you just go on vacation and you come back and there's no big, huge inbox that you're buried in.
Nope. There's no little,
so that's
there's
a big
no little
plus.
number when I get back. There's nothing.
Yeah. And then I think one of the things I'd say about the downside is that sometimes, similar to the ER, it can get frustrating because you sometimes see the same patients, you know, back again. And a lot of that goes back to the social determinants of health, like you said. I mean, some people just cannot manage their conditions outside of the hospital. And so you do sometimes can get a little frustrating seeing the same patients bounce back and things. So that's one of the downsides that I saw. But I did like the hospital environment too.
Yeah, I will say, so there is definitely frustration that can occur when you're seeing the same people again. And I got a really good kind of thing that helps me with that from another PA who works in addiction medicine at our hospital. So I was like, doesn't it bother you that you're talking to them every time, giving them the same advice, you're trying to help them and they keep coming back? And he was like, no, they deserve a chance every time. And so, that really helped kind of shift my perspective of like, you're right, like they do deserve a chance every time because this might be the time that they are able to, get the resources they need, or maybe that social determinant changed. So that does kind of help, but it still is frustrating.
Yeah, that's good. And one other thing I thought of too that is great about the hospital, and you touch on it when you talked about the team, but like pretty much anything you need. If you need a lab, you just have the lab drawn,
Yeah.
and it usually comes back, fairly quickly. If you need a certain diagnostic test, of course, this is variable by hospitals and what they have, but we're talking about larger urban hospitals, a CT or an MRI and things. That is available to you as opposed to, again, family practice where you're like, gosh, I just wish I had a CBC to know to answer this question. You can just get it in the hospitals. Can you tell us a little bit about some of the other opportunities that there are to work kind of as a hospitalist or kind of connected to or similar to a hospitalist?
Yeah, there's kind of two main other roles that we do in our group. People think of hospital medicine always as being like the primary service, but we do have a consulting service, and specifically we do that over on the behavioral health unit. So, and it's pretty much exclusively PAs and NPs that do those consults. And so someone who's admitted to inpatient psychiatry, anything medical comes up, they consult us and we go do the consult and give our recommendations and things like that. So if you don't really enjoy it, having your own patients or doing admissions, like that's a great place for you because you just get to answer questions and help out.
Yeah.
Another kind of cool opportunity that we have, call it HP Direct is what it's called, but it's basically a transfer center. And so during the day between 9 to 7, a PA or an NP is staffing those transfer calls. So there's a center like where there's nurses or paramedics kind of taking the initial information, and then they connect us to the referring provider. And we get to decide, like, sure, like this patient does need one of the metro hospitals, or they don't. They could go to this other, hospital out, we call it the Valley, which is just kind of right outside of St. Paul.
Yeah.
So, we're kind of helping direct flow traffic too, and like getting patients like where they need to be at the most appropriate setting, while also balancing other patients that do need to come to maybe a higher level of care. So that's kind of a cool role that we have.
You have 3 different jobs that you bounce between, like, so you can be doing several days of rounding and or several days of admitting or several days working at this consult service. So you get a pretty good variety in your job.
Yeah. And that keeps it interesting, I think. So
yeah, I think that's really, really cool. So what are some of the personality traits that you think people should have or that help people do well as a hospitalist?
Yeah, I think definitely attention to detail is important in hospital medicine because sometimes, you're getting a lot of labs every day or every other day, and, you might miss an abnormality if you're not paying attention. And that could be, the patient's developing an acute kidney injury and you need to catch that early. And then I think people too that do like that interpersonal kind of communication and teamwork, because you are working constantly in a team. You can't do it by yourself. You need all the other specialties and departments. And so if you kind of want to just go to work, see your patient and leave, I think hospital medicine isn't going to be quite the best fit for you. And then definitely you have to be kind of like a problem solver. So if you like kind of, have some frustration tolerance, like trying to solve problems, I think it's a good place to be too.
Yeah. And you have to be able to kind of synthesize a lot of information especially when you're doing the admitting, because you may have previous hospital records and different things that you have to look through to see what's going on with this patient. And you have to kind of be able to do that relatively quickly and formulate, an overall impression before you go see the patient as well.
Yeah.
So money, we always have to talk about money because it's not why, I always say this, it's not why you should pick a specialty, but it's important to know if you're considering a specialty. And this is also hard to talk about because where you are in the country really makes a huge difference. But if you could give us some idea either of a range or kind of in your area, what you would expect somebody to be kind of an average wage for a hospitalist.
Yeah. I would say that in general, being inpatient versus outpatient like family medicine, you're going to make more. In our area, you should expect, depending on your years of service or years of experience, somewhere between like 130 and like 170. So a lot of people end up falling kind of in that middle range. typically new grads aren't starting in hospital medicine, so they're usually entering with some form of experience. But I would say usually between like 130 and 170 is a good ballpark number.
Yeah, and I should have asked you when we were talking about the schedule, the 7 on, 7 off. Some people really love it. Some people tolerate it. Some people hate it. So, because it's hard to really understand what it's like until you work it, because 7/12s or working 7 days in a row, you're like, oh, that's not too bad. And I get 7 days off. But I think the reality tends to be a little different. At least I'll share after your answer, what I thought about it. So what are your thoughts about that whole 7 on, 7 off and advantages and disadvantages?
Yeah. So I love it. I love the 7 on, 7 off. I feel like I'm on vacation every other week. The downside can be is, I'm contracted or paid to work a certain number of weeks a year. And so if I want 2 weeks off in a row, because I want to do like a vacation or something, sometimes I have to work 2 weeks in a row later. So I have to work 14 days in a row. And so that's where it can kind of get tricky, or you could see a downside is they... you have to give those weeks somehow.
So you guys don't get PTO at all?
We don't. No.
Yeah.
Yep.
And that's different because the hospital I worked at, I mean, I'm not saying that yours is unique. I'm just saying that's another thing that differs. That's the kind of theme of this specialty is that we can kind of give you an idea, but until you interview at a place and find out exactly how they do it, you'll have, kind of just a rough idea. But the hospitals actually had PTO, and so they were able to, take a week and put it with their weeks off. So they actually had 3 weeks off in a row, which can, be really great. I guess one of the downsides to me, and of course I'm significantly older than you are. So when you get to the end of, and we work 7/12s, I think you work like 7/10s, but at the end of 7/12s, it really took a day or two of just like recovery time, to like sleep and just, start feeling energetic again, like where you want to go do something. So really then you end up having 5 days off, which is still 5 days in a row, but just something to think about. If you're trying to find your fit in medicine or just curious about what the different specialties are that PAs and NPs work in, then check out this playlist here. Thank you for joining me, and as always, take care, stay sane, and I'll see you next time on the Medicine Couch. Bye.